To thank you for making time. It was relatively abrupt because we had a lot of activities after the conference, too many activities in preparation for the conference, and the conference was barely last week, but we are here again for the call. This shows commitment, and I want to thank you all. I hope you people are hearing. Hello?
Yes, we are hearing.
Okay. So I want to thank you all that you've been able to make it for this call. That shows the level of commitment to the community. So I welcome you back from Abuja, from that hectic week. And those of us who are not there, you must have gotten the feedback of what happened, but it was a great conference. And there was a lot of learning. And we had our satellite session, which concentrated on catching up where we left from Uganda. And I think the country teams that were there were given pieces of nuggets on how to finalize their country plans, where we expect some feedback before the end of the year, or just after the new year begins. Otherwise, I want to take the opportunity to invite you again for this call. This call, as you could have seen from the invite, we are handling management or monitoring, viral load monitoring for pediatrics and adolescents, because this continues to be a challenge for many country programs. But they are best practices that are being implemented as QI projects. There are some centers of excellence that have got good or proven practices that have made a difference. So today we are going to be discussing monitoring, viral load monitoring for children and adolescents. And we are delighted today to have a subject matter expert by the names of Dr. Fiona Musiime from Baylor College of Medicine, Children Foundation in Uganda. Baylor is an IP who is specialized for pediatric HIV care. So they have a lot of experience over the years. So we are delighted to have them share their experience, and I believe we'll have a lot of lessons to learn. Then after that, we will react by sharing our experiences and asking questions. As usual, you keep yourself on mute when you are not speaking. Use the chat to indicate if you have any questions, and put your questions in the chat. Please, those of us who are at hubs or just indicate within the chat so that we can keep a track of who was on the line. Even when you are in a hub, indicate how many of you are there and write down their names so that we can be able to track how many of us have been on the call. Otherwise, I want to welcome our presenter. I hope your screen is shared, Dr. Fiona. So I take the pleasure to welcome you to take us in the next 20 or so minutes.
Good afternoon, everyone. It's a pleasure for me to share with you experiences on management of HIV viral load non-suppression among children and adolescents, which is still a major challenge for all of us. My presentation outline will look at a brief background. We'll look at viral load uptake among children and adolescents, as well as viral load suppression among children and adolescents. And we'll discuss some of the strategies we are using to improve viral load suppression among children and adolescents in Uganda. So as a brief background, as Dr. Charles introduced, Baylor Uganda is implementing a comprehensive HIV package for children, adolescents, as well as adults at a Center of Excellence clinic in Mulago National Referral Hospital, as well as Fort Portal Regional Referral Hospital. And we also support satellite clinics, health facilities in 8 districts in Western Uganda, which is the Rwenzori region. Our mission is to provide a healthy and fulfilled life for every HIV-infected and affected child and their families in Africa. And our mission is to provide high-quality, family-centered pediatric and adolescent health care, education, and clinical research worldwide. So as a brief background, WHO recommends viral load testing, monitoring as the preferred approach for monitoring response to antiretroviral therapy, as well as to diagnose and confirm ART treatment failure. It's recommended that children and adolescents under the age of 19 years with a suppressed viral load should repeat their viral loads every after 6 months. We have made progress in treatment of children and adolescents living with HIV. However, treatment outcomes among children and adolescents still lag behind when compared to adults. This is in terms of their ART coverage, in terms of their retention in care, as well as their viral load suppression. Similarly, in Uganda, according to a report from the Uganda Population HIV Impact Assessment for 2016-2017, revealed the same, that viral load suppression among children below 15 years was at 39%, and this is way below the adults at 59%. So as we work towards achieving the 90-90-90 targets, or the 95 targets, the third 95 targets, it's very important for us to find what strategies will work for our children and adolescents to achieve viral load suppression. When we look at our coverage, national coverage for viral load coverage for children and adolescents below the age of 15 years, we see between 2017 and 2018, there was a slight progressive improvement in the number of children tested for viral load. From 52% in 2017 to 68% in 2018. However, we still see about 32% of our children and adolescents under the age of 15 years, as per 2018, did not receive a viral load test. Those who are eligible but did not receive a viral load test. So this still shows us that our coverage for viral load for children and adolescents is also still suboptimal. And some of the barriers that we've learned that to viral load uptake include children and adolescents their viral load should be every 6 months. However, we find that there is no timely tracking for those who are eligible for viral load testing. We also see that there is overrepresentation of children whereby caretakers come to the facility and they leave their children at home. And so this affects taking the viral load samples from these children. We also see that school times affect viral load uptake for children, and even those who are non-suppressed, their repeat viral load is not timely done. However, we've implemented some strategies which have been shown to help to improve the coverage among children and adolescents. And one of them is supporting health facilities to conduct routine health education to improve the knowledge for viral load for the need for viral load. And this is done for the caregivers, for the adolescents themselves, for the clients, and also for the health workers. In order to improve coverage, we conduct viral load demand creation campaigns, and these help they help to reduce the backload of those children and adolescents who are eligible that have not done a test. And these are usually done during the holidays when children are back from school. We have specialized clinics for children and adolescents, and these provide an opportunity to integrate viral load testing in these specialized clinics. In order to track those who are eligible for viral load, the Ministry of Health recommended using of stickers to track those who are eligible for viral load. And also the ministry recommends the use of CQI projects on viral load uptake, and these have helped to facilities to monitor their viral load coverages. We'll go on to discuss the viral load non-suppression among children and adolescents. By June 2018, our viral load suppression rates overall nationally was at 77%. That is for children, adolescents, and the young people from 0 to 24 years. However, we note that the viral load suppression varies by age, and you find that was 52%. And as they increase in the age, you find that there's an improvement in their viral load coverage. So you find from 52% for those who are below 2 years to 87% for those who are 20 to 24 years. And this tells us that there's a need for, as we look at these children, as we manage these children, there's a need for us to pay close attention to the very young children because of their poorer health outcomes which have been indicated. We're going to discuss some of the factors that affect viral load suppression among children and adolescents. And studies have indicated increasing antiretroviral drug resistance. According to the WHO drug resistance report of 2017, we saw that infants exposed to PMTCT programs, WHO estimated drug resistance of about 21%, and this compared to 8.3% among those who had no previous treatment exposure. In a study done by Kitio published in 2016, revealed a prevalence of about 10% of acquired drug resistance among Ugandan children below the age of 12 years. And this indicates to us that these children have already acquired this resistance, and some of them will be resistant to the drugs that we actually give them. And it takes us to the point of suboptimal drug regimen. We have limited choice of pediatric formulations, and some of the pediatric formulations have difficulties in administration. For example, they have unpleasant tastes, causing the children to spit them and vomit them, and so they are not taking the appropriate drug that is prescribed. We still see overrepresentation as a factor that children to the hospital, then health workers will not take an appropriate dose, which determines the dosing, an appropriate weight, which determines the dosing for the children. And so this greatly affects the changing of the dose and the uptake of the appropriate dose for the children. We see psychosocial issues affecting adherence of our children and adolescents. And this can be categorized into the caregiver factors, where you have children who lack committed caregivers, or those who have multiple caregivers, or elderly caregivers who do not supervise these children while taking their drugs. And also you have fine caregivers who themselves have adherence issues, will not support their children to adhere to their treatment. We also have drug-related factors, whereby you have adolescents or children who refuse to take their medicine just because they are tired of taking the medicine. Poor palatability of some of the drugs, high pill burden, and also frequent dose changes. Because as children grow older, then their doses keep changing because of their weights. But some of the children, or the caretakers may not take this as something important as they change their doses. We still have issues of child neglect and abuse, and this affects them in that they don't have anyone who is actually supervising them. Stigma and discrimination still remains, especially in adolescents who are at school, and this causes them to fear to take medicines while at school. And also school times affect the adherence in the adolescent, as well as non-disclosure issues to both the child, the adolescent, and family members. So some of these adolescents do not know why they're taking their medicine, and so it's not that important to them. When you look at the clinicians' factors, delays in case management of the non-suppressed, and delay in taking appropriate decision during intensive adherence counseling sessions, as well as switching those who are already failing on first line onto appropriate regimen. So the Ministry of Health has recommended a 10-point package for management of non-suppressed, and we'll briefly go through it. So when viral load results are received from the laboratory, this should be sorted and separated into those which are suppressed and non-suppressed. This helps clinicians to be able to track those who are non-suppressed. And for those who are non-suppressed, Ministry recommends to apply red stickers. These are to flag off the patients such that the clinicians know who need immediate attention. And then those who are unsuppressed are to be called back to the facility for intensive adherence counseling. And the first intensive adherence counseling session should be conducted within 7 to 30 days of results return. These adherence counseling sessions should be then documented on forms, intensive adherence counseling forms, and to support the completion of 3 intensive adherence sessions. After 3 good consecutive intensive adherence counseling sessions, a repeat viral load is then taken. If the repeat viral load is non-suppressed, then you evaluate the patient for switch to a second line. And on a second line, a repeat viral load is taken 6 months later. And if it's still non-suppressed, then we remove a sample for drug resistance test. And depending on the results, we'll determine the 3rd line regimen which is chosen. At the health facility staff are to form viral load focal teams. And these include clinicians as well as laboratory staff. And these are supposed to conduct routine review of non-suppressed files. The ministry has recommended and has put in place a non-suppressed register, and this register helps to track those clients who are non-suppressed until their outcomes. And at the facilities are supposed to make switch teams, switch committees, who are multidisciplinary. They involve different cadres from the health facility, including counselors, including clinicians. And this, before switch is conducted, they're supposed to sit and discuss the failing patients. Integrating viral load monitoring talks into morning health education sessions, as well as linking those who are non-suppressed to community structures for peer support. The ministry also has recommended facilities to conduct quality improvement projects with initiatives for managing of the non-suppressed clients. I'll briefly share a cascade. This is taken from the Rwenzori region, which shows how the management of the non-suppressed looks like. And this is for the period of July-September 2018. 6 months prior to July-September 2018, we had a total of 349 children and adolescents, 0 to 19 years, who had non-suppressed viral loads. Of these, 264 completed 3 intensive adherence counseling sessions. That means 76% completed the 3 intensive adherence counseling sessions, meaning about 24% did not complete their sessions. And of those who completed their sessions, 184 received a repeat viral load, meaning only 70% received a viral load. And of these who received a viral load, 108 had improved on intensive adherence counseling. That means their viral loads were suppressed. So giving us about 59% of our children had a suppressed viral load after intensive adherence counseling session. So this cascade shows us the different areas where we need to strengthen as we manage our clients who are non-suppressed, and where some of the children and adolescents also get lost along the cascade of care. However, a 59% improvement of those who had, these were people who are children and adolescents who had been reported to have very good adherence. However, they did not suppress after adherence counseling, meaning these probably needed better regimens for them, and the first line regimen probably had like resistances to them. So as Baylor Uganda, we've incorporated the 10-point package into the strategies that we are using to improve viral load suppression among children and adolescents. And in this, we have put up specialized clinics, that is for the adolescents, as well as the children, as well as also for those who are non-suppressed. In these clinics help to give more health education, particularly to the children and adolescents, about adherence. And also every bi-monthly, we hold adolescent peer support group meetings whereby adolescents encourage each other, as well as they are taught about some topics that can improve positive living amongst themselves. We're using play therapy as one of methods to enhance adolescent adherence, especially among children, and we're supporting health facilities to strengthen the intensive adherence counseling sessions that they give to clients who have non-suppressed viral loads. We're supporting health adolescents to conduct economic strengthening activities. And in these activities, it helps to give them hope. It helps to give them some income, helps also improve retention in care. And this has been shown to also improve their adherence to treatment. For those who are non-suppressed, we recommend home visiting to actually assess the issues that are happening at home that could be barriers and who are affecting viral load suppression. In line with the Ministry of Health, we are optimizing treatment regimen. Basically, that is lopinavir-based regimen, especially for our children who are under 2 years, as well as those who are actually failing on first-line regimen. We support health facilities in conducting pediatric and adolescent mentorships every quarter, and also support health facilities to conduct switch meetings and case conferences. In the picture below, we see a team, a multidisciplinary team, has clinicians, the caregivers, they're discussing a child who is failing and trying to find out options for the child. In line with the Ministry of Health recommendation, we are integrating CQI approaches to support health facilities monitor their data to improve viral load suppression among their clients. I'll briefly share a case which highlights the role of a community in achieving viral load suppression. This is a case of Epi, an 11-year-old who started her ART in 2015. Both her parents passed on and she was staying with a maternal auntie who is a peasant farmer and cultivates in another district. So for the time she goes out to work, the district is about 75 kilometers from where she works. So in those seasons, there's no one at home to supervise her taking of medicine. And she's left with just fellow adolescents at home. So there's no one to supervise her medication. Epi's initial viral loads were suppressed. However, her viral load in April last year was 24,000. And her repeat viral load came back to be 26,000. Ideally, Epi should have been switched to a second line regimen. And at the health facility, Epi kept on keeping her appointments, and she kept on reporting to have good adherence to her treatment. However, before a switch could be conducted, a home visit was done at community level. And at community level, we discovered that although Epi was keeping her appointments, although she reported good adherence at the facility, she was actually not taking her medicine. So she had learned how to answer the questions at the facility. And at home, we found all those white tins of untaken medicine. No one was supervising her treatment, and she reported to be tired of taking her drugs, as well as feel burden in taking her drugs. She was attached to a community health worker who was to support and supervise her taking medicine, and 4 months later, her viral load was suppressed. So conducting home visits and community engagement for all non-suppressed viral load clients is critical in their management, because we saw a discrepancy between what was being reported at the health facility and in the community. So what are key, as we end, our key messages? We need to timely track eligible children and adolescents for viral load testing every 6 months. Clinicians should optimize and use more efficacious drug regimen for children and adolescents and minimize overrepresentation of these children. Is need to strengthen psychosocial support, including adherence counseling given to children and adolescents, both at health facility level as well as community level. Schools should be engaged to support adherence and reduce stigma among adolescents with HIV, more efficacious and convenient ART drug regimens for children and adolescents. So these are some of our references, and I thank you.
Okay. Yes, Fiona, thank you very, very much for that very elaborate and insightful this presentation of your experience of taking care of children and adolescents. I know many country programs are faced with many challenges related to pediatric HIV care and adolescents. So I think the audience is actually waiting to have an opportunity to react. But otherwise, I think it's been very spot on, and I thank you very much. So I open it up to the audience for us to respond, react in terms of asking questions or sharing some experience, especially on some of the practical things that you've been able to do and that have made a difference. So I open it up.
Yeah, hello, Charles.
Yes, yes.
This is Dennis from Malawi.
Mm.
Actually, I should thank the doctor for the very good presentation. At least it gives an insight on what strides have you made up there in Uganda. But then looking at our context here in Malawi, as you have rightly put it, managing adolescents and children living positively is not easy, especially when it comes to adherence to drugs and also to ensure issues of routine viral load tests. But I wanted to find out three things. I wanted clarification on three areas. One of the areas is the issue of disclosure. How are you managing disclosure issues in Uganda? At what age do you disclose to a child? And also what steps are taken when it comes to issues of disclosure? The second area is the issue of peer support groups for adolescents. You've rightly said that you put children together in groups so that they encourage each other to remain adherent to drugs. Here in Malawi, we are using what we call teen clubs, where adolescents come together to a health facility where they meet providers who provide information, relevant information to the kids. But you find that some communities live very far areas from the health facilities, some maybe 30 kilometers, others 25 kilometers. And in some cases, these are child-headed households or, where maybe there is only a widow taking care of the kids, and the transportation to facility is not easy. How do you manage these peer support groups for the adolescents? Are they only facility-based or they are also community-based? How do you handle those groups that are organized far away from the health facilities? The last thing is on the various cadres working together to help children living positively. I think that, to me, it assumes that you have enough cadres, those that can really organize themselves, come together to support these children. Otherwise, with acute shortage of staff like we have here in Malawi, where a health facility would have maybe 3 providers or maybe 4 workers or even 2 at a health facility, I find it to be challenging to create time where different cadres would come together to support these children. I just wanted clarification on those few areas. Thank you.
Okay. Fiona, respond. Hello, Fiona.
Thank you so much, Dennis, for your questions. I'll start with the first question of the issue of disclosure in Uganda. Age of disclosure is 12 years in Uganda, which is the same age of consent for HIV testing. And however, of course, disclosure starts as understanding and the child's intellect. And so, although the age of disclosure is 12 years, we hope that by 12 years, a child has been disclosed to. It can start as early as as early as 5 years, as early as 7 years, when a child starts to ask those questions. And the steps of disclosure, of course, it also depends on the child's intellect and child's ability to understand. You disclose probably bits as the child is able to take in or a child is able to understand. But we hope by the age of 12 years, the child has been disclosed to. But we also know that sometimes disclosure is very difficult for caregivers. And for those, we try to identify caregivers who need support to be disclosed to. And for those, together with the health workers at the facilities, they're supported to disclose to their children. But the steps of disclosure, it depends on the child's intellect, and it can start as early as when the child starts to ask those questions of why am I taking medicines. Peer support group meetings, I totally agree, because we also have some challenges of some children who are coming from very far communities and those who are coming from child-headed households. What has been supporting us is because we've been having support from the comprehensive partners that support the programs, for example, PEPFAR funding. And for most of these peer support meetings, we facilitate them with some transport to come to the facility. However, in the program, there are also economic strengthening activities. We support caregivers to be part of economic strengthening activities, whereby from these activities, they'll be able to get some money to help them with issues like transport to the facility. And for these children who are coming from child-headed households, in most of our areas, we have community-based organizations and the OVC platforms. And some of these children who are in these child-headed households are enrolled into the OVC platform. But to say that is still also a big challenge, especially for our children who are in child-headed households, who have no one to supervise their taking of medications. It is a challenge. One of the questions was, are there facility-based and community-based group meetings? What we have been implementing are majorly facility-based peer support meetings. However, starting last year, we rolled out the facility community framework. And in this, we are engaging community-based organizations who are also supposed to conduct and support peer support meetings in the community. However, this is something which is still new. It has not been rolled out, but it's also in the plan to support also when we look at the differentiated service delivery model, to also offer the service in the community. However, for now, they are majorly facility-based. And then shortage of staff. How do you create time for different cadres to meet and discuss? Because we have we've separated the clinic in order for health workers to have time to manage the non-suppressed. We've tried to support health facilities to separate the clinics for the non-suppressed, such that they have very few clients who probably come on those clinic days, and that helps to reduce the workload of the clinicians at that time. And usually for the case conferences, of course, sometimes it's a big team, but sometimes you may have like 3 health workers who create time to conduct these case conferences. And sometimes we have teams from the ministry or teams from the regional mentors or the district mentors who support health facilities to conduct these case conferences.
Okay. There are some questions from the chat. The first one is from Mr. Kabuje, which has been partly answered. The remaining bit of the question is that who does the disclosure to the child that they are HIV positive? Is it the health caregiver or the parents? And then the other question is from Dr. Pasco. How do you make sure that the switch committees do not create bureaucratic and bottlenecks when managing non-suppressed patients? And then the other question is how quickly is the non-suppressed viral register updated? And then the last one is what kind of economic strengthening activities do you propose for those adolescent children that need to be in school and not working? And then the other last question is from Lucibiro, and he asks, what is the option if there is no easy access to resistance testing, that is HIV drug resistance testing, just after exhausting some intensive adherence counseling classes and discover there is no improvement after the drug switch? Is there any other option? And then the last one is from Zakari, and he says the first one, how do you prioritize strategies? The strategies you highlighted in the presentation, how do you strategize them? And then how do you prioritize them, and then what strategies do you find most successful and impactful?
Okay, those are a couple. So Fiona, can you please respond to those?
Thank you so much. Yeah, I'll keep asking Nicholas to repeat for me some of them because I didn't get most of them. So the first question was, who does the disclosure? The disclosure is supposed to be done by the caretaker or the parent. For those who are not able to disclose, because some parents find it very hard to disclose, then the caregivers are supported, a health worker supports them. However, in the disclosure session, the caregiver we build the capacity of the caregiver to be able to disclose to their child or their adolescent. So it's majorly the caregiver who does the disclosure, though a health worker may support a caregiver to disclose to a child or the adolescent. Then Dr. Pascoe's question, how do you make sure that the switch committees, maybe Dr. Nicholas can help me repeat that?
Yeah, how do you make sure that the switch committees do not create bureaucratic and bottlenecks when managing non-suppressed patients?
Do not create bottlenecks.
Yeah. How do you make sure that they act fast when managing non-suppressed patients so that the decision doesn't drag and take long?
Okay. So one of the challenges is actually delays to switch failing clients, because one of the things that we found is that some of our health workers are not very confident to actually do the switch to actually switch a child from one regimen to another, and so they need support. So what we've been doing, in addition to the switch committee, because most of them usually meet when they have a client, or at least once a month, to discuss these failing clients. However, we as an implementing partner also support health facilities, at least on a quarterly basis, to see how many, to track and see how many have need a switch and how many have done the switch, because we are supporting about 134 health facilities. So we have a pool of mentors, district mentors and regional mentors, who additionally support the health facilities to make sure that the switch meetings are happening. But it is the decision to actually switch children from a first line to a second line for many of our health workers is a bit challenging, and most of them are not very confident to actually switch their clients. The next question was about economic strengthening activities. What economic strengthening activities are the adolescents engaged in? So some of the activities we engage them in, both for the adolescents as well as their caregivers, are saving schemes, what we call VISLA, that's village local saving schemes, whereby they put their money together and probably do something together for a living. But some of the other activities is for adolescents. We have put some entrepreneurship skills like bead making, craft making, and some entrepreneurship skills like tailoring to support them. And maybe, Dr. Nicholas, you can help me read that for the economic strengthening activities. The question on economic strengthening activities.
I can help you, Dr. Fiona. I'm just wondering, for children and adolescents, they are supposed to be in school the whole day. So when do they get time to have those economic activities? You know, if you go to school at 9 in the morning until 5, how do you do that? Then you have to do your homework in the weekend. So that's what I'm trying to
So for the caregiver, when I mean children, it's not that the children are in these activities. We are talking about their caregivers, the people who are looking after them.
All right.
And the adolescents usually target those adolescents who are not cool. Yeah.
Okay.
And then
and just for the question, just a second. So for the question about those switch committees, have you ever think of having like a network with this kind of ECHO system that would support the people to switch? Because if the switch committee meets like quarterly, you know, I find it late if every month or quarterly you verify that people have actually been switched. I mean, it might take 6 months before you realize that somebody is still on a failing regimen. So I really wonder if this is fast enough. I mean, it's reassuring for the clinician to know that there's a committee behind the decision, but for the patient, I mean, they still have to wait a very long time before the correct decision is taken. So I really wonder if that really benefits the clinician or that benefits the adolescent. Just a comment.
Okay. So it's not that all facilities will sit and have the switch meeting every quarterly, but the health workers at the facility, because we do like a technical support supervision, but on a monthly basis for some health facilities, but some sit more frequently than on a monthly basis to support to have that discussion of the switch committee meetings. However, for the ones who have difficult cases, we have a toll-free call center, which is a national call-free center to support any health workers or who have questions and who need any clearance or any guidance on management of any children who are complicated for them. So for that, there is a toll-free line that they can call and get guidance. Dr. Nicholas, help me with the question of drug resistance, the option for drug resistance.
Yeah, someone was asking what you do in case there is not easy access to HIV drug resistance after exhausting the intensive adherence counseling classes, and you discover that the person has not improved even when you switched them for another drug.
So for drug resistance, this is usually handled at a national level. And at the Ministry of Health, there is a third line committee whereby when health facilities identify that there's a person who needs a drug resistance testing, they will send their samples to one of the national labs for testing for drug resistance. I don't know if that is adequate.
So Nicholas,
then how do you prioritize strategies, and what do you find most successful? So for the strategies that, of course, for management of non-suppressed, strategies that improve adherence, because we want them to actually adhere to their medicine, because that will what will help them to improve their viral load suppression in the long run. So strategies that support intensive adherence counseling sessions, strategies that support home visiting to support those who are not adhering to adhere well, have helped us to have shown to be more successful. For example, in the case that we discussed, a case of supporting children who are failing or who are non-suppressed, especially in the community, and attaching them to a community health worker, attaching them to a community-based organization to support their adherence. So strategies that support adherence help to improve viral load. But we also know that apart from adherence, poor viral suppression is due to resistance. So being able to timely identify those ones who the viral load failure is because of the poor adherence and then the resistance, and being able to switch them to an appropriate regimen also helps to improve viral load suppression.
Okay. Dalila has a question. Dalila, I see your hand up. Can you ask your question?
Yes, sorry. Am I unmuted? Okay. My question was around the prioritizing of the strategies. I had typed it in as well.
Okay. Okay.
Yeah. Yes.
Yes. I also have a question on adolescents in school. What has been your experience in, first of all, monitoring them and making sure they adhere to their treatment? What are the unique issues associated to this cohort of clients from your experience?
Hello?
Hello? Did you get the question? Fiona?
Hello?
Yes, did you get the question?
Yes, for adolescents in school.
Yes, yes.
Okay. We've found that adolescents in school, actually one of the difficulties in school we find with managing adolescents is the adolescents in school. Because of issues of stigma in school, some of them still are not very confident to take their medicine while in school. But through the peer support meetings, those are some of the issues that are discussed. And we also had trainings of some of the school teachers and the school nurses to be able to support some of the children who are in their schools to be able to adhere to their treatment. But stigma in schools still affects adherence, especially for the adolescents.
Is it a requirement for a kid to inform at least the sick bay that they are HIV positive? Is that information given to the sick bay? How would the school support?
So what we did, we trained some school nurses and some school teachers for schools where our adolescents were going to, and they were supposed to support the adolescents in those schools to adhere to their medicine. So of course, in the peer support meetings, we tell them, but of course, some of them will tell you issues like, I don't trust my school teacher, or I don't trust the school person there. So sometimes there are individual challenges for each of the children. But during their meetings, that is one of the things that we encourage them, especially in the fight of stigma at school. But it's still a challenge.
Yeah, Chair, there is a question in the chat box. It's from Dr. Benson Abraham, is asking how do you deal with the economic factor when it comes to transport, since most of children come from far and poor family? How do you deal with economic factor when it comes to transport, since most of the children come from far and poor family? And is also asking, how do you run your clinics and how do you set the client's flow? How do you run your clinics and how do you set the client's flow, starting from what is done, how and when? And then lastly, what cadres are almost there to provide art services to the pediatrics and adolescents? And that's from Dr. Benson Abraham. Thank you.
Yes, Fiona, the floor is yours.
Yes, for the economic factors, how do we manage transport challenges? So for some of the activities, for example, the peer support meetings, we support these children to come to the facility with some transport, because this is under one of our funded programs. However, for their economic strengthening and sustainability, that's where we engage community platforms like the community-based organizations and OVC platforms, the Orphans and Vulnerable Children's platforms. And here they support, as we had earlier discussed, they support economic strengthening activities, such that we hope from these strengthening activities, the caregivers and some of the adolescents are able to earn some living to be able to support themselves to come to the facility. And then we've also integrated their their clinic days in their peer support meeting days. So they don't have to come to the facility for many different activities. Then how do you run your clinic? What is the clinic flow? For the clinics, first of all, we've separated the clinics. We have clinics for the adolescents, and then we have what we call the family clinics. These are clinics for the children and their caregivers. So the clinic flow in these clinics, we have in the adolescent clinics, we have adolescent peer leaders. These are who support health workers to run these clinics. And they will do health education at the clinic. And this is with an overall supervisor who is an adolescent focal person. So at the clinic floor, we have health education, then they will do triage, and then they'll be seen by the clinician. But also in the clinic, we support like play therapy, just to keep them engaged at the time they come to the clinic. Then what cadres provide pediatric services? We have supported training of health workers at cadres of clinical officers. These ones have a diploma in medicine, cadres of medical officers, as well as even nursing officers, to be able to support the provision of pediatric services and ART care. So because in most of our facilities in the rural areas, they don't have, in our Center of Excellence, we have medical officers and pediatricians. However, in rural settings, we have, you'll find clinical officers. These have a diploma in medicine, as well as nursing officers who have been trained in, and at each of the facilities, we've trained an adolescent focal person who has been trained in provision of adolescent care.
Okay, so thank you very much, Dr. Fiona, and thanks very much for the audience for that engaging discussion that we have had. I think we have picked a lot of information. That presentation will be made available in the next few days, so you can go over it again. Do you have any other materials that you're making available, Fiona?
I had included the links.
Okay, on the
references.
presentation.
Yeah.
Okay. So the links there in the last slide will lead you to resources that can be tapped to help with care for children. So that brings us to our discussion. So I know we are going into the festive season. We wish you very, very safe and interesting and happy season until when we meet again. But just a reminder of the few things that we expect to be done on your end. There's a waste management template that was circulated where we needed countries to send back the status of their waste management protocol or waste management services. I know a number have sent in, but if you haven't, if any country has not sent in their template, please do, because that will determine how your subsequent support is going to be planned. Then, country work plans. Country work plans, we still wait. We gave ourselves, I think, up to the first week, end of first week of January, to have all your work plans ready. But we are reminded that actually co-planning begins on the 16th of January. And we were advised to check. It's already available actually online, where we go to see the scope of the co-planning, and then we start seeing how our action plans fit into that co-planning that is coming, and we should be involved in the co-planning to ensure that our plans are actually inserted in there. Dr. Pasco, did you have any communication to make?
Well, no, I think you saw. I mean, we are almost, we are really at the hours. So let's just make sure that the resources that are provided by Fiona also end up on the website, so you don't have to go back to the presentation, but we can post them. And also, it would be great if we could hear from your respective countries. And I know we have a lot to learn from South Africa, from Malawi, from Zimbabwe, all of you. Can you also share your experience in managing children and adolescents, so that we can have another session? So maybe Dr. Charles can follow up with you. We would love to hear about your experience as well.
Okay, so the time has come almost to our terminal end. But remember, we have a WhatsApp group that is open 24/7. Let the discussion continue, because we can't exhaust everything on this session. But whatever remains, please, let's continue pushing questions. And Fiona will also be invited to answer some of the questions that may come along that we've not been able to answer. So keep pushing your questions on the WhatsApp group. Let's get answers from colleagues. Have a Merry Christmas and a Happy New Year. Bye.